Good morning. I'm Matt Wilson, the Anatomy, Pathology, and Oncology Trustee. It is my great pleasure to provide the history of the Mildred Weisenfeld Award for Excellence in Ophthalmology. The award was established as a tribute to Mildred Weisenfeld's outstanding contributions to the field, which include the founding of Fight for Sight in 1946. She believed that by encouraging research and researchers, the result would have a greater impact. The award is presented to an individual in recognition of distinguished scholarly contributions to the clinical practice of ophthalmology. The 2025 Weisenfeld Award is presented to Geeta Vemuganti, DMP, FAMS, MD, Senior Professor in Dean School of Medical Sciences, University of Hyderabad. She has contributed significantly to establishing and expanding ophthalmic pathology as a specialty and a tool to understanding diseases. It is my pleasure to present this year's Weisenfeld Award to you, Dr. Vemuganti. I'm now pleased to introduce past ARVO President and the 2024 Weisenfeld Award recipient, Dr. Martina Jaeger, Professor of Ophthalmology, Leiden University Medical Center, who will review Dr. Vemuganti's life and introduce her lecture.
A good morning to all of you. It is a very great pleasure to introduce to you Dr. Vemuganti. She herself will discuss her work, but I will tell you a little bit more. Who is Dr. Vemuganti? A rock star in pathology, a fantastic mother, wife, grandmother, and a superb friend to her friends. She comes from a loving family with a lot of brothers and sisters who all grew up to be either in the military or to become doctors. She chose a career in medicine. Apart from her career, she has many hobbies, including a great love for dogs and a lot of handwork, which comes in very handy if you are a pathologist. She has been together with her husband, Ramesh, who is here in the audience, and she is blessed with a son and a daughter who had the most magnificent marriage, each of them in India, which was also visited by several of their international friends. Her son is here in this audience today. She has 4 grandchildren. She was educated in India. Coming from Hyderabad, she went to high school and then wanted to get a medical degree. She studied clinical pathology and was a diplomat of the National Board, but she wanted to learn more and decided to find the places where she could learn that. She could not have asked for more. She selected the best of the best. She came first to the Tata Memorial Hospital and then in the US to the Doheny, the Wills Eye, the AFIP with Dr. Ian McLean and Professor Zimmerman, and then later on with Dr. Bob Volberg and Deepak Edward. So she received the best training one could imagine. Then went back home, consultant pathologist, and was quickly hired by the Avi Prasad, the top institute for this in India, to become their pathologist. But being also good at administration, she was asked to come and become Dean of the School of Medical Sciences of the University of Hyderabad. Now she retired from that. She continued to be a pathologist and is now a distinguished pathologist and scientist professor at the LVPI. One of the things that she told me was that ARVO is a fantastic place for making friends. Long-time friends. I have the pleasure of having been a friend of Geeta for 25 years. And Her achievements have been not only in making friends and bringing people to Hyderabad, she has many publications in pathology, has managed to get very many grants, national and international, and is a fellow of the Royal College of Pathologists in Great Britain, the National Academy of Medical Sciences, and Indian College of Pathologists, and the Telangana Academy of Sciences. Internationally, she has contributed to the W.H. Blue book on eye tumors, the classification, which is considered the top of what you can do as a pathologist. She has not only been active at home, she has been a very active contributor to ARVO. When she visited the United States, she was told about ARVO and has been coming here since 2000. She has been the chair of the Program Committee Anatomy Pathology, mentor for the leadership program, and a waiver keynote lecture. In addition, she is on many journals as editor and has been on many other ARVO committees. For this, she has been honored nationally and internationally. For instance, by the American Academy of Ophthalmology, the International Society for Ocular Oncology, and she has lectured at NASA. ARVO has already given her a silver and gold fellowship. But today, we celebrate her research, her work for the many patients that benefited from her beautiful work as a pathologist and the research that she has done. And for that, we will greet Professor Geeta Vemuganti, who will now present the Weisenfeld lecture. Professor Vemuganti.
A very good morning, ladies and gentlemen, my ARVO family. It's a distinct pleasure and honor to be here in front of this august audience to deliver the Mildred Weisenfeld Award in this beautiful city of Salt Lake City of Utah. The stem cells have been fascinating to everyone, and as a pathologist, we have been looking at two different aspects of these, the one which comes for help for regeneration, and one, when it goes bad, it forms a tumor. And this is the work I'm here to share with you. And I would like to pay my regards, though we didn't have the opportunity to meet her, but it would have been wonderful. I'm truly grateful to ARVO and to Ms. Weisenfeld for setting up all the precedents of raising grants to do translational research in ophthalmology. Salutes to my gurus, and they were tough gurus, I would say. Professor Ratnakar, late Professor Ratnakar from Nizam's Institute, and Dr. G.N. Rao, Gulapalli Nageshwar Rao from L.V. Prasad Institute, who is here to cheer me today. And their training was excellent. Dr. Ratnakar insisted that I go and sit behind the slit lamp to see all the corneal lesions myself. And Dr. Rao would insist that I would do a very good clinico-pathological correlation of all the cases that I see. And I hope I lived up to their expectations. And both were my guide and co-guide for my thesis during my residency on surgical pathology of cornea. My career took a few turns. I was told that if you are trained as a pathologist, be in general pathology for a few years. And I took that advice, and I stayed in pathology. I was trained in onco, general surgical pathology, where we were used to specimens from head to foot. And it was a very enriching experience. And at that time, we had to do both hematology, cytology, surgical pathology. And then my mentor, Dr. Rao, felt that I would be appropriate to lead the pathology team. And I thought I was ready to take that up. And this institute, L.V. Prasad Eye Institute, I don't have to introduce to this audience. It's one of the best institutes, the WHO Collaborative Center for Prevention of Blindness. And it taught me many things. And on top of it, I probably have the richest experience of signing out more than 40,000 ocular specimens in this institute. And it also initiated me into the field of vision science and research for which I didn't think I was prepared or ready, but it is the confidence of Dr. Rao and Professor Balasubramaniam who thought I should take up research. And after a few years, when I got this call from University of Hyderabad, I thought probably it's my payback time. And I went into a university. I had to defocus into a more general area. And this world-class University of Hyderabad, which is an institute of eminence, gave me a very rich experience in academic leadership, teaching, mentoring. It has a beautiful campus, and that was the picture where I was the first dean to walk into the university with about 11 men deans. And after my superannuation this January, I'm very happy to be back at LV Prasada Institute to continue my journey. I would like to share my experience of two aspects of the stem cells. One for regeneration and our experience with limbal cultures, oral cultures, co-cultures, and notification or demonstration of presence of limbal stromal cells, and also the lacrimal gland. And I will also talk about experience of working on cancer stem cells in retinoblastoma. And I would use the same format so that we are familiar with it. As a pathology resident, we were told that all the cells in the body, from head to foot, can be divided into three types of cells. The one called labile cells, which regenerate throughout your body, and they have a portion of cells called stem cells, and they're easily repaired. They are cells which are stable cells, which are there. The stem cells are there in that compartment, but they come to the rescue SOS, as and when required, like liver and other mesenchymal tissues. There are some permanent tissues in our body, like central nervous system, skeletal muscle, cardiac, and glomerulus, which will never regenerate in our lifetime, and hence, they probably have to look for organ transplantation. So does it mean that if we know adequately about these tissue cells or the adult stem cells in these tissues and know the culture properties, we could potentially go for regeneration or replacement of these damaged tissues? On the other hand, if the same normal adult stem cell undergoes a lot of mutations which are irreparable and it does not repair itself, then it makes what is called as a cancer cell or a cancer-initiating cell, cancer stem cell. We don't have the opportunity in the clinical setting to identify this cancer stem cell. So what we end up is looking for the needle in the haystack, looking for these cancer stem cells in the mass of this tumor. And there have been, all the cells in the tumor are not cancer stem cells. Only a portion which can form and with specific properties are called cancer stem cells. So on this part of it, the cancer stem cells which make tumors, we don't want them to grow. We want to curtail them by using targeted therapy. So the totally different functions of the stem cell. How do we define these cells? This is very general for the basic audience. So these are undifferentiated cells capable of differentiation and capable of self-renewal. The property of differentiation varies within the hierarchy of stem cells, whether it is embryonic or adult or fetal cells. These properties are governed, these properties are, in addition to self-renewal, it's an asymmetric division where one daughter cell goes back into the stem cell compartment and the other stem cell goes into the path of differentiation. Niche is something very important. All these properties of stem cells, they have, unlike the general concept, they have a low mitotic activity. They are in the quiescent phase. They are in a very special environment called as microenvironment of the niche. And the reason, in fact, when people ask me, why are we having cancers? After so many years, I wonder why we don't have cancers. What is that stops us from having these? And that's because of the error-free proliferation of these adult stem cells. And these properties of stem cells are governed both by intrinsic factors as well as extrinsic factors. And now we understand a little more about the niche or the microenvironment of these stem cells. Whether it is all or none phenomena is something that is being evaluated, and we don't know enough of this microenvironment. I'll start with my story of limbal stem cell. Virendra Sangwan, who was my friend during my residency and his fellowship, one day over a cup of coffee said, you know, you have been working on retinoblastoma cultures, and here is a need of culturing limbal cells for potential clinical transplantation. And he sees a lot of cases of chemical burns in his clinic, and that's when we started this project of whether we can culture and characterize these limbal epithelial cells. And all the pictures on the right will be my mini infantry who helped me do this work. Fortunately for us, there was a lot of excellent work which was already established. And the evidence of limbal stem cells, we did not have to do that. It was already well established that the limbus has stem cells which populates the corneal epithelium. And if that gets damaged, it leads to a condition called as limbal stem cell deficiency, where the conjunctiva comes over the cornea and the patient loses vision. And another thing was, there was already a precedence by Grazielia's group and Resai group that instead of the preferred practice pattern at that time was taking few lenticules of limbal tissue from the good eye and transplant it to the diseased eye after surgical debridement. But instead of that, knowing that these stem cells can be cultured, can we take a little tissue that is 2 millimeters of tissue, expand it into a sheet of epithelium and transplant back to the patient? And we had the regulatory approvals of that time. And what we developed was a xeno-free explant culture of limbal cells. We were hesitant to use feeder cells because they were of xenosource, and the salient features of our culture include that amniotic membrane, which the surgeons were already using in the clinical practice to reconstruct the ocular surface. And therefore, we did not go for a new scaffold. We denuded the amniotic membrane, made explant cultures, prepared the human corneal epithelial media, and we avoided the cholera toxin and used only the recombinant growth factors. And since we did not have a culture insert which segregated, what the pathology department resources came handy. We used a glass slide used in the pathology department, and we cut them into 3 bits, and they were easy to autoclave, and they served as a culture insert. And the amniotic membrane prepared in our eye bank was wrapped around it as you would tuck a baby at bedtime. And that's how we prepared this, and we made small bits from these explant tissues and explanted them on this amniotic membrane. And the cultures, these are already established, and at that time, Pellegrini's group had later published about the P63. So we made cultures, we did the ultrastructure, we did the stratification. It took about 1 week to 2 weeks to stratify. The more you waited in the culture, the more stratification happened. And the stem cells were ABCG2 at that time. And one of the things that initially, when the stem cells labeling was not available, what we did was a traditional label retaining index. If you label all the cells by BRDU and chase them in the experiment, you can pick up the pulse, do the pulse chase experiment, and at the end of 4 weeks, you have what is called as a label retaining cells. So in the culture, we had stem cells, we had differentiated cells, and transient amplifying cells, which is what a stem cell is expected to do. And Indumati from our lab had joined by then, and she helped us establish this protocol for in nature protocol, where the biopsy, harvesting, transportation, explanting, and then culturing characterization was published. So it went on to clinical phase. Virender was the one surgeon for all these cases, and later joined by Sayan Basu, who is with us now. So in nutshell, the biopsy was harvested from the good eye and made into a sheet of epithelium. And after surgical debridement, along with the amniotic membrane, was transplanted to the ocular surface. And those patients which required subsequent penetrating keratoplasty, and this is one of the best proofs of cell therapy. Even in bone marrow, which is one of the best stem cell therapy, we don't have access to bone marrow biopsy to see if they have. The only evidence is we do the cell count. So here was the tissue available to us. And as per the NIH guidelines, for the cell therapy includes the cells should be in the required type, in the required numbers, should survive, network, integrate, contribute to function, cause no harm. And all these criteria in this model were found to be successful. And the in vivo confocal microscopy further assisted in monitoring the stratification. And they formed their own basement membrane, as is evident. And all the criteria of NIH guidelines for cell therapy were completed. So what was the outcome of all these cases that we did? It's very interesting. Those patients who had unilateral disease, autologous tissue was harvested, and the success was about 70%. Those patients who had both eyes damaged, they had to go for allogenic. And most of the times it was they were related donors, but they had to be immunosuppressed. And even in these cases, about 60 to 70% was success was noted by my colleague Virendra Sangwan. Even in children, and one of the sad part of these chemical injuries, which are mostly caused by alkali burns, the bleaching powder or the calcium hydroxide, as we call it, because of, I guess, lack of regularity in monitoring these. They're easily available to children, and we had many patients of children with these injuries, and 50% of them could be helped with this technique. And subsequent PK was also successful. Interestingly, if you know the Reader's Digest cartoon of Life is Like That, we went through that same cycle. We started with direct limbal transplantation, went ahead with the explant culture, ex vivo, and then Sangwan and Sheila McNeil came back with the technique, why can't we try it in situ? A combination of direct limbal transplantation with the explant culture technique became a success story, and that is called as SLET, simple limbal epithelial transplantation. And I don't know what we are going to end up with next. In cases, those who had bilateral injuries and who required immunosuppression, and Virendra and we wondered whether we could go ahead with the oral culture mucosa cells, which was done by Kinoshita's group. And in our, we used the same explant culture. We characterized these cells. And these markers, we found that all the three, limbal, conjunctiva, and oral, share many markers. And one of the things that Ambati had reported about the SFLT, interestingly, we found that this was secreted high by limbal, but not by other cells. But however, in our hands and in our setup, the cells survived, networked, integrated, but did not contribute to function in terms of they brought along with it a blood vessel leash, and therefore Virendra did not want to pursue this further. How do we address the cases where we have both the conjunctiva and the limbus damaged? And for this, we designed what is called as a co-culture, where we put the limbal in the center, conjunctiva at the periphery, using a ring barrier to segregate these. And it was done in 40 cases with about 60% success. A novel finding of our study was the presence of these spindle cells. Initially, we didn't know the source, what these could represent. And Naresh, who's in the audience here, used the International Society for Cell and Gene Therapy criteria of culturing them by looking at the phenotype, doing the clonal assays, culturing them. He was also working on rat bone marrow cells, mesenchymal cells, and we found a striking similarity with this, as is evident here. All the markers that were found in bone marrow stromal cells were also found in the limbal stromal cells, including HLA-DR being negative. And that was, MSCs have been reported in bone marrow, adipose tissue, cord blood, and many organs, and we could contribute to the identification of these cells in the limbal stroma, including the plasticity to adipocyte, osteogenic, cartilage, and neural-like lineage. Did it lead anywhere? So why this? We were at a crossroad how to call them mesenchymal stem cells because of the resistance by other community. And the reason we could contribute to this is the gene expression study confirmed that the limbal epithelial cells are a combination of stem cells, differentiated cells, as well as other cells. They have specific growth factors, they have specific cytokine profile. The limbal-derived stromal cells, on the other hand, show different growth factors, different cytokines, and what's most important is they are complementary to each other. If you find a receptor here, you find a ligand there. You find a ligand release there, you find a receptor here. And based on these features, we suggested that these stromal cells are part of the limbal cell niche and probably are the intrinsic feeder cells in our culture system. And subsequently, it went on, and Sayan Basu is pursuing its potential clinical application. While we were working on these, we had an invitation from International Atomic Energy Agency, and the question was, how would you address any radiation-induced damage through potential cell therapy? And to my mind, what occurred was dry eye, especially the aqueous deficient dry eye, is common after radiation, and whether we could first provide proof of that and establish the lacrimal gland cultures. We found that those eyes which received radiation and then had to undergo exenteration, those three precious tissues demonstrated that the lacrimal gland is totally damaged. Majority of it is damaged after radiation. It could not grow, and it did not show all the markers that were seronegative. And we found out that at the end of almost 4 years, 70% of these patients developed dry eye. I almost lost my oncology friend after I made this report, saying that I do everything to protect the eyes from radiation, and you still say that you have the dry eye. So then we went on to do the lacrimal gland cultures, and we used the explant culture technique and used different scaffolds to do that, and evaluated the secretome in the conditioned media. The stromal cells, almost 1.5 decades later, Vivek and Sayan helped me establish the mesenchymal cells in that. And this was the first human lacrimal gland cultures where we could have sheets of epithelium, fibroblast-like cells, and myofibroblast-like cells, which was already published. What's important was you could push them to make duct-like structures. 3D spheres, mammospheres, prostate spheres, and we went ahead and called them lacrispheres in lacrimal gland. The most important thing is they were functionally competent. That means they secreted the tear substances, which included lysozyme secretory IgA and lactoferrin. And you could make them cry a little more by adding carbachol. The evidence of stem cells, I'm not still sure what they are, but one of the potential markers was c-KIT, which was identified actually in xylospheres in salivary gland. And other than ABCG2, we still have to look for an accurate marker. And a few years ago, Aparna and Jilu contributed to the mesenchymal stem cells, again following the same criteria of plasticity, trilineage differentiation, colony formation, and comparing them with the epithelial cells that they are not of epithelial lineage and they are similar to the bone marrow mesenchymal cells. So to summarize the work on adult stem cell for regeneration, limbal and conjunctival cells were helpful and subsequently replaced by what is called as a SLED by Sangwan et al. And COMET, we did not find much promise. I find limbal stromal cells would be of great value for clinical application, and also the lacrimal gland cells. The cancer stem cell property is something that we wanted to evaluate. What happens is, if all the radiotherapy or chemotherapy removes the dividing cells, but what remains is the underbunker enemy, and that is the cancer stem cell. And we first started the work on the primary tumors, and since all the assays could not be done, we went to the cell lines and then developed different models. And here we use this strategy for identifying the cancer stem cells using the self-renewal properties. And when the phenotype was to be established, we pulled out all the markers that were published in cancer stem cells and then used single marker, multiple markers, size, and then we narrowed down that the small size with low side scatter and forward scatter with 44 positive and 133 negative are the putative cancer stem cells. Since all the assays could not be done on primary cells, we did it on the Y79 cells. And could we generate the drug-resistant clones in the Y79? Yes, we could, and that was demonstrated by serial exposure to carboplatin. And these Y79 cells were characterized using the same method of colony formation, migration assays, and the most important is they were chemo-resistant. As you can see in the graph in the middle, they were cytotoxicity assays showed they were chemo-resistant. Can we generate? Yes, we can generate drug-resistant clones by serial exposure to carboplatin. And you can see the overexpression of ABCG2 genes, and there is the high resistance to further exposure to any drug. And you can see the IC50, which has drastically enhanced. Do they form tumors, as was one of the criteria? And we used the chick embryo for the lack of resources. This was the work done at university, and we used the old model of chick embryo. And so the eggs were incubated. A window was made on day 3. The transplantation of cells was done on the chorioallantoinic membrane on day 7 and sacrificed on day 14. And after sacrificing, the CAM was evaluated for the label cells which were there forming nodules, and the embryo was evaluated by imaging to see for the evidence of spontaneous metastasis. And this is the evidence. This work is, the primary tumors is not yet published, and we found that the tumor cells are formed more in the CSC population. They have high fluorescence, they have more evidence for metastasis. And this is the histological proof that these tumor cells have gone and populated the CAM as well as metastatic to the brain. In the Y79, similarly, we found that the CSC population, even in the drug-resistant clones, there was more formation of the tumor cells, high fluorescence intensity, and more evidence for metastasis. And here is the histological proof that the cells have gone. In one case, as you can see here, that's a uveal tissue which shows the tumor cells, and one was the liver which shows the tumor cells. And the gene expression of the tumor cells within the CAM showed overexpression of some of the markers like VEGF, PCNA, and which was more in the CSC population. Can we reverse this chemoresistance? Obviously, that was the translation part of it. And my colleague Anand Kondapi from University of Hyderabad, who had experience of preparing the lactoferrin nanoformulations, we used those formulations to see if we could reverse them. And as you can see in the cyto, it looks like a busy slide, but if you see on the arrow, so compared to the standard drugs, the lactoferrin formulations had a high cytotoxicity. And you can see that towards the later half when the dose of the drugs is higher. And we could show that both with carboplatin as well as etoposide. What could be the role of EVs? So the EVs are what is called as an extracellular vesicles, which are secreted from most of the cells from the body, including the tumor cells. Why are they important? They are important because they are the cargo, or the ways that the cells communicate with each other. And Radhika and Jyoti went ahead working on this. So the first thing was, in addition to Swati's group, which was also looking at biomarkers of EVs in patients who had radiation therapy. So our approach was to see what is the best way to isolate them, characterize them, and then see if these EVs can be loaded with the standard cells, and if we could give the therapy to the cells. And then another important thing that the EVs do is they prime the metastatic site for homing of these tumor cells. So we created an experiment where we could mimic what probably happens in the bone marrow by exposing the bone marrow cell EV to the tumor cells, the tumor cell EVs to the bone marrow cells. And the characterization, we used multiple methods to identify these EVs, and we found that the sucrose ultracentrifuge method was one of the best, and it had the standard markers of CD63, TSG101, CD9, HSP17, and you can see the monodispersive nature, and the NTA showed the amount of EVs that we can have, and that's the EM of these. So once we were satisfied they fulfilled the criteria of the small extracellular vesicles, we went ahead attempting to load them with the drugs. And this is the drug encapsulation, which we did using the carboplatin. And we've documented that these carboplatin can be loaded into these EVs, and they are released in the cells at the pH of 5. And they are internalized because these EVs were labeled, and you could demonstrate here that these EVs are taken up. We exposed them to the cell line again, and we saw that these were accepted by the cells, and this internalization was documented. The uptake of EVs did not cause any damage to the cells, but they showed an almost equal uptake, but the release was much high by EVs. Do they show cytotoxicity? Yes, they show, as you can see in the graph, the red one shows the EVs which were loaded with carboplatin, and it showed that there is a higher efficacy, and the IC50 values also confirm the same, and they cause increased apoptosis. What happens in the niche? And this is unpublished, one of the posters is there, and this is something that is applicable, probably it could be extrapolated to all the tumors and in their metastatic sites. So what we did was we took the tumor cells, and the EVs of these tumor cells were exposed to the bone marrow mesenchymal cells. And we found that they are internalized. There was no difference in the cell viability of the bone marrow cells after being exposed to the tumor EVs. They didn't disappear. They are there, they're proliferating, thriving. They contribute to migration, they contribute to cell differentiation, and they have a change in the secretome profile when exposed to these tumor cells. What happens when the bone marrow EVs are exposed to the tumor cells? And we expect in the niche both would be happening simultaneously. And what we found that, again, these bone marrow EVs were internalized by the tumor cells. There was no change in the viability, and there was a huge increase in the cell proliferation, migration. The cell apoptosis was decreased, meaning that it helps them to thrive there, and the secretome profile changed. To summarize, the evidence of the tumor cells show an enhancement of stemness. That means all the factors are contributing to the tumor growth in the metastatic site, which is a mimic, it's an in vitro condition. And these are the overexpression of the stem cell markers. So what possibly happens at the niche is that both the bone marrow cells have an effect on the tumor cells, and the tumor cell EVs have an effect on the bone marrow cells. And while these have already been listed, what's important is together they contribute to promoting the tumor at the metastatic site and probably contribute to the proliferation. So to summarize the work on the cancer stem cells that we did, we could document that these cancer stem cells are defined by a particular phenotype and size in the primary tumors as well as in the cell lines. And it was possible to derive what is called as a drug-resistant clone by repeated exposure to carboplatin. And we could generate what is called as a chick embryo model. And this is one of the grants that we had with UCARY, Liverpool, where they were working on uveal melanoma for the chick embryo, and we were working for the retinoblastoma using the chick embryo model. And we could document that the tumor is initiated in these CAMs. It shows spontaneous evidence of metastasis, both in the primary tumors as well as in the cell lines. And we found it to be very simple, cost-effective, and it could serve as a model for testing drug efficacy, which is in the pipeline for us. The nanoformulation, especially the lactoferrin, which my colleague Anand Kundapi has prepared, and we find a lot of potential of these nanoparticles to reverse the chemoresistance. And nanoparticles is quite compatible, and this discussion is going on for further potential clinical application. And the EVs, which is the buzzword these days, and these small particles which are important cargo for all the intercellular communications, we found that they play an important role in retinoblastoma, and they could potentially serve as a vehicle to load your drugs. And the specificity, in fact, we had the opportunity to discuss this with Randy Sheckman, the Nobel laureate from University of Berkeley, and he gave excellent inputs on how we could process it further to see for the efficacy. Interactions at the niche at the bone marrow niche or the metastatic niche is one of the potential areas where an intervention could be explored. So coming back to the two properties of the stem cells, what we could use for regeneration is one of the successful models of limbal stem cell, which gave us a lot of insights, and it was a rewarding translational research which not only helped patients but also paved way for a new technique called as SLET. The chemoresistance in cancer stem cells is not of just of an academic interest, but it is a practical problem, and the time has come to explore the targeted therapies against these cancer stem cells. What's more intriguing is how these two diverse functions of the stem cells in the same niche are controlled. And that is something that it's very intriguing and challenging to work on. And I guess the future directions would be looking for targeted therapies for the cell cycle switch this way or that way, and the niche of both the metastatic as well as the primary tumors. And I live by this. Research means I don't know anything, but I'm willing to find out what it means. And that's what I shared. And the most humbling experience is whatever you do, my niche was this family. My father, a medical officer in the army, was a man who said never give up. And my mother was an epitome of love and who believed in the mantra of hugs. And my siblings give me a lot of support. All the growth factors come from my siblings. And my big brother is almost like a mentor and a father figure to me. And there's always another family of the in-laws which comes. And I have stayed 40 years in research and 40 years with my married life. I don't know which was tougher, but my second family has given me unconditional support, and I believe family is like institutions. And institutions has all sorts of people and requires a lot of support and acceptance of people. And we have 3-generation people in uniform, decorated officers, and I'm extremely proud of them. And I'm grateful to life and family in general. Ramesh, my husband, who is here, of 40 years, and he was my friend before that, so it goes on to maybe 50 years. So after the tour of duties, which I call it, both personally and professionally, and I superannuated this January, where do I take myself? I would like to continue with my research as the opportunity given by Dr. Rao at LVPI, and I would love to mentor and teach, and most importantly, I'll get back to my friends, my other people who probably I ignored. And the comradeship, what you develop in your school, college, is something that which will take you forever. And this is my mini infantry. If I have forgotten or missed anyone, it is definitely not by intention. I may have, the gray hair must have missed them. But thanks to all my clinical collaborators, Virendra Sangwan, the daredevil surgeon, Santosh, who taught me all about ocular oncology, and all my colleagues, Dr. Rao, Professor Balasubramaniam, Dr. Das, and my mini infantry, as I call, all my collaborators from LVPI, from university, from IISc, NIN, and National Institute of Animal Biotechnology, all the funding agencies, which made it possible for me to do this work and present before you. And I'm extremely grateful to all my colleagues and ARVO, and I bring greetings from my country. Thank you so much for patiently listening.